Okay, so you want to own a plastic surgery clinic. You picture a sleek facility in Beverly Hills or Miami, a waiting room full of patients who drove 2 hours to see your surgeon, and a business built on procedures that cost $10,000 each and take less than 2 hours to perform. You imagine high margins, wealthy clients, and a practice that operates on its own momentum once the reputation is established. That picture exists, but it belongs to a specific kind of clinic operator who spent years building the physician relationships, the marketing infrastructure, and the patient retention systems before the revenue matched the overhead. The American medical aesthetics and plastic surgery market generated $21 billion in revenue in 2024, growing at 8% annually across both surgical and non-surgical categories. And the gap between a clinic generating $4 million per year and one generating $400,000 on the same number of treatment rooms in the same city comes down almost entirely to decisions made before the first patient booked a consultation. By the end of this, you will understand exactly what a plastic surgery clinic costs to open in 2025, how the revenue model works across surgical and non-surgical procedures, what the physician compensation structure does to the owner's take-home income, and why the clinics that reach $3 million in annual revenue look almost nothing like the ones that plateau at $800,000 despite operating in the same market. Plastic Surgery Clinic covers 3 different business models that share a waiting room and almost nothing else financially. A physician-owned practice where the surgeon owns the business generates the highest revenue per procedure but cannot scale beyond one person's physical capacity, while a management services organization model where a non-physician owner contracts with physicians allows expansion across multiple locations without the owner holding a medical license. A medical spa model focused on non-surgical procedures, meaning Botox, fillers, laser treatments, and body contouring, requires a physician medical director but runs day-to-day through nurse practitioners and registered nurses, generating lower revenue per treatment but far higher volume with substantially lower overhead per room. These 3 models require different capital structures, different regulatory compliance frameworks, and different physician relationships, and choosing the wrong one for your market and your capital position determines the financial outcome before the first patient books a consultation. A clinic performing surgical procedures under general or IV sedation must obtain accreditation from one of 3 bodies: the American Association for Accreditation of Ambulatory Surgery Facilities, the Accreditation Association for Ambulatory Healthcare, or the Joint Commission, and the accreditation process requires physical plant inspections, equipment audits, and credentialing verification for every physician, with requirements that vary by state in ways that determine startup cost and the range of procedures the facility can legally offer. Accreditation costs $8,000 to $25,000 in fees and takes 6 to 18 months to complete. And a clinic offering surgical procedures before accreditation is finalized faces state medical board sanctions that can result in closure and physician license suspension, making the timeline a hard constraint rather than a planning target. States like Florida, California, and Texas require office-based surgery permits separate from accreditation, and the physical plant requirements for those permits, covering procedure room dimensions, flooring materials, and ventilation specifications, add construction costs that a developer who has never built medical space will consistently underestimate until the first set of bids comes back. The build-out cost for a plastic surgery clinic runs substantially higher than a general medical office because the physical requirements of a surgical environment dictate specifications that standard commercial construction does not meet and that most general contractors encounter for the first time on a medical build-out project, producing change orders that add 15% to 30% above the original bid. A procedure room capable of hosting surgical cases under general anesthesia requires a minimum of 250 to 400 square feet with laminar airflow HVAC, medical gas piping for oxygen and nitrous oxide, dedicated electrical circuits for surgical equipment, scrub sinks adjacent to the room, and floor and wall finishes that meet sterile field requirements, and constructing that room from shell space in a commercial building in Miami, Los Angeles, or Dallas costs $150,000 to $300,000 before a single piece of equipment enters the room. A two-procedure room surgical suite with a pre-op and recovery area, a consultation room, reception, business office, and supply storage runs $600,000 to $1.2 million in construction costs in most major markets before equipment purchases, and adding a laser suite with proper electrical capacity, ventilation designed for laser plume evacuation, and mandated eye protection systems adds another $100,000 to $200,000 in construction cost on top of the laser equipment itself. The equipment list for a plastic surgery clinic represents a capital investment that most people entering this business underestimate by a factor of 2 before they start getting actual quotes. A full surgical suite requires an operating table, anesthesia machine, patient monitoring equipment, electrosurgical unit, suction, surgical lighting, backup power, and the sterilization equipment to process reusable instruments, with a complete surgical equipment package running $250,000 to $500,000 for new equipment and $120,000 to $250,000 for refurbished. A clinic adding body contouring and laser treatments compounds that cost significantly, with a cool sculpting system at $100,000 to $150,000, a fractional CO2 laser at $80,000 to $120,000, a radiofrequency device at $60,000 to $100,000, and a picosecond laser at $80,000 to $130,000, pushing total equipment investment for a fully equipped two-room suite with laser and body contouring capability to $600,000 to $900,000 before a single patient arrives, depreciation and maintenance contracts running 8% to 12% of purchase price annually. The physician compensation model determines the financial structure of the entire clinic, and a salary arrangement at $350,000 to $600,000 per year creates a fixed cost the clinic must cover regardless of volume, while a percentage of collections model at 35% to 50% aligns incentives with production but generates income variability that complicates planning and produces months where the physician earns more than the owner. A surgeon who also owns the clinic captures both the clinical and facility revenue from their own cases, the highest earning structure, at the cost of concentrating the entire business in one person whose injury, malpractice restriction, or burnout eliminates both the revenue stream and the operational leadership in the same event. Clinics that reach $3 million in revenue without depending on a single surgeon's schedule do it by building the non-surgical volume to a level where the injection team covers fixed costs on the weeks when the surgical suite sits at 60% capacity. The revenue structure of a plastic surgery clinic splits into surgical procedures and non-surgical treatments, and the margin profile of each category differs enough that clinics built primarily on one versus the other operate as different businesses. A rhinoplasty procedure generates a surgeon fee of $5,000 to $12,000 and a facility fee of $2,000 to $5,000, with the total case generating $7,000 to $17,000 in revenue for a procedure that takes 2 to 3 hours of operating room time and requires significant pre-operative consultation and post-operative follow-up. A Botox treatment generates $400 to $1,200 depending on units placed, takes 15 to 20 minutes, requires no operating room, runs through a nurse injector earning $45 to $75 per hour, and produces a patient who returns every 3 to 4 months indefinitely if the result meets their expectation. And the clinics that reach $3 million in annual revenue derive 40% to 60% of that revenue from non-surgical treatments that their surgeons did not personally perform. The patient acquisition cost in plastic surgery is the marketing expense that blindsides new clinic owners who assume that good surgical outcomes and word of mouth will fill a schedule. Google advertising for plastic surgery keywords in competitive markets like Miami, Los Angeles, and New York costs $15 to $45 per click on terms like rhinoplasty surgeon and mommy makeover, and a clinic converting 3% of website visitors to consultations and 30% of consultations to booked procedures spends $500 to $2,000 in advertising cost to acquire each surgical patient. A clinic generating $2 million in surgical revenue from 150 cases per year spends $150,000 to $300,000 annually on Google, Instagram, and TikTok advertising, and that spend is not optional in markets where 3 competing clinics within 5 miles run identical campaigns. While a surgeon who posts consistent before and after results content builds an organic following that reduces paid acquisition cost in a way that no amount of Google spend alone replicates. The malpractice insurance cost for a plastic surgery practice represents one of the highest specialty insurance burdens in American medicine, reflecting the frequency and severity of claims in a field where patients carry high aesthetic expectations and where a complication affecting physical appearance generates emotional distress that juries in states like California and Florida have historically translated into verdicts that exceed policy limits. A board-certified plastic surgeon in Florida pays $40,000 to $80,000 per year for a claims-made policy with $1 million per occurrence and $3 million aggregate limits, and a surgeon with any adverse claims history who performs high-volume liposuction or who operates on patients with BMI above 30 at elevated rates pays at the top of that range, or faces coverage restrictions that require them to either reduce procedure volume or switch to a carrier with less favorable terms. The clinic carries separate premises and professional liability coverage, adding $15,000 to $30,000 per year on top of individual physician premiums, and a clinic adding a second surgeon doubles the physician premium exposure while the facility coverage cost increases by only a fraction of that amount, making each additional surgeon both a revenue opportunity and a fixed insurance cost that the clinic must generate enough incremental production to justify. The non-surgical revenue model is the part of the plastic surgery clinic business that generates the most predictable income and the highest return on the equipment investment when it runs at proper utilization. A clinic with 3 nurse injectors working 5 days per week, each seeing 8 patients per day, generates 120 Botox and filler appointments per week at an average revenue of $700 per appointment, producing $84,000 per week in injection revenue before product cost. Botox and filler product cost runs 20% to 30% of retail from Allergan and Galderma, leaving a 70% to 80% gross margin on injection treatments that overhead can support at a fraction of the cost required to run a surgical suite, and a clinic building injection volume to 400 treatments per week, alongside a surgical schedule of 6 to 8 cases per week, generates $3.5 million to $4.5 million in annual revenue from a facility that cost $1.5 million to $2 million to build and equip. The membership model is the revenue innovation that the fastest-growing aesthetic clinics have adopted over the past 5 years, and it addresses the fundamental problem that non-surgical aesthetic treatments produce in a business that depends on consistent monthly revenue. A clinic that sells a membership for $199 per month that includes 1 Botox treatment per quarter, a 20% discount on additional treatments, and priority scheduling access converts a patient who books 4 times per year into a patient who pays the clinic $2,388 per year in predictable monthly revenue, regardless of whether they show up for every appointment. A clinic with 500 active membership patients generates $1.19 million in annual membership revenue before any additional treatment purchases, and the conversion rate from non-member to member tracks directly with the quality of the post-treatment follow-up process, which is the system most clinic operators fail to build before they start worrying about patient acquisition. The income that a plastic surgery clinic generates for its owner depends on the revenue model, the physician compensation structure, and the non-surgical volume more than on any other variable. A solo surgeon who owns their practice performs 8 surgical cases per month at an average of $10,000 in combined surgeon and facility fees, and runs a medical spa generating $80,000 per month in non-surgical revenue, produces $1.76 million in annual gross revenue, and after the surgeon's own draw of $350,000, facility overhead of $600,000, and marketing costs of $200,000, nets $610,000 in owner owner income from a business that required $1.5 million to $2 million to build. A two-surgeon clinic with 4 injection rooms, a membership program, and $4 million in annual revenue nets, $800,000 to $1.2 million for the owner after physician compensation, overhead, and marketing costs in a year where the non-surgical volume runs at full capacity and the surgical schedule stays consistently booked. The plastic surgery clinic owners who build businesses that generate wealth rather than income share one characteristic that separates them from the ones who work 18-hour days and still struggle to make payroll at the end of a busy month. They treated the non-surgical side of the practice as the financial engine from the beginning, building the injection team and the membership program before they purchased the third laser or added the second procedure room. Because recurring non-surgical revenue covers fixed overhead in the months when surgical volume dips for seasonal reasons or when the surgeon takes 2 weeks away from the operating table. And that consistency is the difference between a business that compounds year over year and one that resets every time the schedule has a slow stretch. The reputation that fills the surgical schedule takes years of consistent outcomes and patient referrals to build, and the non-surgical revenue that funds those years does not appear by accident in a business where a laser that costs $120,000 needs 600 treatments at $200 per treatment to pay for itself before it generates a single dollar of margin, and where the injector who produces 40 treatments per day needs a patient pipeline that the owner built before the injector arrived.